Hey guys, today we're going to talk about obsessive-compulsive disorder, which is more commonly known as OCD. First, we're going to go over some of the early history of this condition, followed by some of the basic terminology that you'll need to know, and then we're going to go over the causes and some of the treatments that are available. Lastly, we're going to talk about how it's represented in the media, so without further ado, let us begin. Around the 17th century, obsessions and compulsions were thought to be the symptoms of religious melancholy. In 1660, Jeremy Taylor, who was a bishop in Ireland, referred to obsessive doubts when doubts are resolved in some of his writings. In 1621, Robert Burton, the author of The Anatomy of Melancholy, referenced individuals who were afraid to speak because they didn't want their obsessions to show. In 1691, John Moore, who was a bishop in England, spoke of individuals obsessed with perverted and blasphemous thoughts, struggling to suppress them as they became more persistent. Moving into the 1800s, a French psychologist, whose name I'm not going to try to say, described OCD as a form of monomania or partial insanity that was attributed to a disordered intellect and disordered will. In the 1950s, French psychiatrists abandoned the idea of monomania and attempted to understand obsessions and compulsions within separate categories, which included conditions that we now know as phobias, panic disorder, and the like. The French psychiatrist Dagonet considered compulsions to be a kind of impulsion and OCD a form of impulsive insanity. But what is the difference between impulsive behavior and compulsive behavior? Impulsive behavior is not premeditated, while compulsive behavior is. Theft can be a really good example for this. If someone was to rob a bank after deliberate planning, that would be compulsive robbery. But if a person were to walk into a gas station and pocket a candy bar without thinking about it at all, that would be impulsive theft. Another French psychologist thought OCD was an emotional disease in which the condition originated from pathology affecting the autonomic nervous system. German psychiatry, on the other hand, regarded OCD as a disorder of intellect. In 1877, German psychologist Westphal credited obsessions to disordered intellectual function. His beliefs gave rise to some of our current terminology. In Great Britain, whatever this word is was translated as obsession, while in the United States it was translated as compulsion. The term obsessive-compulsive disorder was the compromise. In the 19th century, modern concepts of obsessive-compulsive disorder began to take form. Psychiatrists at the time were being influenced by intellectual currents, such as emerging discoveries and ideas about chemistry and philosophy. Obsessions became distinguished from delusions, and compulsions were distinguished from impulsions. There was controversy among influential psychiatrists over whether or not OCD was an issue of will, emotions, or intellect. One popular suspected cause at the time was neurasthenia, a diagnostic category that indicates poor tonus of the nervous system. Pierre Janet and Sigmund Freud made a distinction between OCD and neurasthenia. Janet suggested that obsessions and compulsions come from the third stage of psychasthenic illness. During this stage, individuals lack sufficient psychological tension for higher mental processes regarding will and attention. Their nervous energy is divided into more primitive psychological functions such as obsessions and compulsions. Freud's understanding of OCD was heavily influenced by his beliefs about mental structure, energies, and defense mechanisms. He believed that individuals suffering from OCD were maladaptively responding to conflicts between undesirable id impulses and the pull of conscience. He suggested that the thought processes of those suffering from OCD were reminiscent of the anal sadistic stage of psychosexual development. Some of the ways of thinking that Freud was referring to are uncertainty and doubting and compulsive acts that are rooted in superstition. An individual's ego puts up defenses such as isolation, undoing offenses by carrying out compulsions, and reaction formation, which is the process of taking on character traits that oppose the feared impulse. When these defenses do not fully succeed, they create the symptoms of OCD that we still acknowledge today: anxiety, preoccupation with minor disturbances, and the fear of acting out on certain impulses. As the 20th century has progressed, advances in neurophysiology, learning theory, and the like have permitted us to further our understanding of OCD, which leads us into our next section about OCD in today's world.
Obsessive-compulsive disorder is an anxiety disorder that involves two primary symptoms: obsessions and compulsions. About 2 to 3% of the world population suffers with OCD, and about 1 to 2% of children worldwide have the disorder as well. Males tend to have OCD at a younger age than females do, and most people have their first symptoms before the age of 25. Obsession is any recurrent, intrusive thought, image, or urge that is unwanted but cannot be controlled. And A compulsion is any purposeful repetitive behavior or mental activity that is performed in a ritualistic or stereotypical way, generally with the goal of reducing anxiety associated with an obsessive ideation. The severeness of obsessive-compulsive disorder depends on the amount of general life stress. Leaving the condition of the disorder untreated can worsen the symptoms. Examples of different types of obsessions include fear of becoming a victim of violence, fear of germs, fear of causing an act of violence or sexual misconduct, or fear of losing control and harming oneself or harming others. Common types of compulsions that relieve the obsession thoughts, such as fear of contamination, include excessive hand washing, showering, and/or cleaning. Repetitively locking or checking doors is a compulsion someone might do when they have a fear/obsession with safety. Obsessive-compulsive disorder is known to have other coexisting disorders such as anxiety and depression. About 42 to 83% of people experience coexisting disorders. There are several theories leading to obsessive-compulsive disorders such as biological, behavioral, and cognitive behavioral. Biological theory proposes that OCD is caused by a normal serotonin function. Behavioral theory involves a two-stage process by which OCD is developed and maintained. The first step is fear acquisition, which is when a natural event becomes associated with fear and immediately paired with a stimuli that causes anxiety. An example of the article that I got this from is when a knife is paired with a traumatic experience. The second step is maintenance. It involves avoidance and compulsive rituals, which are negative reinforcement because they reduce anxiety. Obsessive-compulsive disorder is not considered strictly hereditary, although biology factors can influence an individual's chances of developing OCD. There is no evidence to support that obsessive-compulsive disorder has something to do with unresolved childhood conflicts.
Since we know that OCD is not necessarily hereditary, nor is it linked to childhood conflict, let's take a look at a case study. In this case study, a 5-year-old girl is examined after exhibiting disturbing obsessions with religion and sexual perversions. These obsessions began 5 days after the girl was given cyproheptadine as an appetite stimulant because she was underweight. The mother of the child said that her daughter became greatly distressed after seeing 2 people kissing on television. She began incessantly asking if God was going to punish her for committing a sin, and she said that she was fearful of doing shameful things to her parents. She said that these thoughts were coming into her head against her own will. Other than her display of religious and sexual obsessions, she did not show any signs of obsession with symmetry, contamination, or any other obsession or compulsion. She had no personal history of any medical conditions that could have possibly triggered the OCD symptoms, but her family history indicated that her biological mother had an anxiety disorder and her biological father had both panic disorder and OCD. The girl was diagnosed with social anxiety disorder, and her obsessive-compulsive symptoms were thought to be induced by the cyproheptadine. Her obsessions stopped 2 weeks after discontinuing the medication. Although past studies suggest that children cannot develop OCD, recent studies have found that children with a family history of OCD or anxiety disorders may have an increased chance of developing OCD while using cyproheptadine. Cyproheptadine is an agonist with multiple different receptors, such as the 5-HT2A and 5-HT2C receptors, which both receive serotonin. Severe reactions to cyproheptadine include hallucinations, sedation, convulsions, heart palpitations, and severe confusion. Although this drug has clear neuropsychiatric effects, it is not usually associated with inducing OCD behaviors. Other atypical antipsychotics, which are drugs used to treat psychiatric conditions, may have a greater impact on the 5-HT2 receptors than the D2 receptors, which are for dopamine, causing OCD symptoms with lower dosages. Some studies have shown that antiserotonergic agents may induce OCD symptoms. The cyproheptadine-induced obsessions in this case may be due to those antiserotonergic effects in the medication.
In order to be able to diagnose OCD, the symptoms need to be severe enough to cause distress or interfere with life. However, many people that suffer with the disorder do experience disruption in social and family relationships, and also it affects their performance at work, decreasing the quality of life. In order for a person to be properly diagnosed, they must acknowledge that their compulsions are excessive and unrealistic. The disorder is poorly treated if a person fails to see the irrationality of their thoughts. There are several different types of ways to treat OCD. One treatment is cognitive behavioral therapy, otherwise known as CBT, which is designed to help a person with the disorder recognize how unreasonable their fear is. Exposure and response prevention, EXP, is another type of therapy where a person is exposed to situations that provoke obsessive thoughts and is prevented from performing the compulsive act. Antidepressants are also known as a way to treat OCD, but they take longer to relieve a person of their symptoms. Patients treated with CBT, cognitive behavioral therapy, achieve up to 65% of OCD symptoms. Most effective treatments is a combination of psychotherapy and medications. A last resort for a person who has tried all other treatments and still has not had any breakthrough with the disorder is neurostimulation, which is a deep brain stimulation used in rare cases where a neurosurgeon implants an ultra-thin electrodes in the brain in order to stimulate a specific region involved with OCD symptoms.
So we know that OCD is a rare but severe anxiety disorder that can have a strong negative effect on those suffering from it, yet many do not seek help immediately or even at all. For these reasons, it can sometimes be called the secret illness. OCD can cause impairment that is similar to that of various psychotic disorders, and it is often associated with more social and occupational impairment than other mental disorders. There is now a multitude of effective treatments for OCD, such as cognitive behavioral therapy. However, a UK study found that the average time for when OCD starts affecting a person's life to the time they actually seek treatment is about 6 years. In the US, it is 17 years. The same study, which was conducted through surveying, suggested that people with OCD and no comorbid disorder were much less likely than people with OCD and a comorbid disorder to receive treatment. It was 14% compared to 56%. Only a little over 40% of the people who screened positive for OCD on National Screening Day actually reached out for treatment. It is possible that people with OCD and comorbid disorders may have sought help for their emotional problems rather than their OCD. Individuals suffering from the most severe symptoms of OCD are most likely to seek out help, while factors such as stigma may dissuade others from getting treatment. The lack of public awareness about OCD may lead to stigma, and it is possible that those suffering from OCD and their family members may not fully realize the seriousness of the disorder. Embarrassment, fear of being hospitalized, and fear of being criminalized are other reasons for not coming forward with symptoms. Many people suffering from OCD felt that their condition was only temporary, not serious, or they were ashamed of the way that they were feeling. The most common reasons that those suffering from OCD do not seek help are as follows. They think they can manage, cannot afford treatment, fear judgment, do not have insurance, are afraid to take meds, don't believe treatment will help, and that they don't believe they have the disorder. These kinds of reasons are known as internal or cognitive factors. Reasons for finally seeking treatment include persistent symptoms, lack of control over said symptoms, interference in their daily lives, worsening symptoms, and hurting the people around them.
Disorder can be serotonin. Nope. Recognize how unreasonable. Oh my God.